Hello, everyone. I wanted to talk to you a little bit about Module 5 and substance abuse. Um, but before I do that, I wanted to make sure everybody was able to take a look at the information about Test 2. It's going to be different than Test 1 and Test 3. It's not going to be proctored. It's going to take you a little bit of time to do the assignment or the test. And so I went ahead and opened it now. It's not due till next month, but I went ahead and opened it so you can talk to your preceptors and do a little research and get that done for the due date. I don't have it in front of me, but I think it's July 20th at midnight. It's in the course and it's on that information I sent, but double check that date. The It'll take a little while for me to grade those, but I'll get them back to you as soon as I can. The computer, of course, won't grade those, so it'll take a little while. All right, let me talk to you about substance abuse. When we talk about substance abuse, of course, it's a repeat of what we've had in 608, 691, 692, and so we're just going to focus on the older adult. Now, we have some GERI units across the state that say 50 and above is considered geriatric. Really, for this course and most of your medications and trials and research, it's 65 and above. They are doing some research out there now for 85 and above, which is kind of interesting. But I wanted to focus on some things related to substance abuse and the older adult. So I'm thinking 65 and above. So most of this is from Kaplan. It's a review from Kaplan and Sadek that was in the readings, but I wanted just to point out a few things. Patients with substance abuse problems tend to have a higher rate of depressive symptoms. I know that's not a shocker to you. We've known for a long time alcohol can increase depressive symptoms. I was just reading a couple of weeks ago about how it can increase anxiety levels, and there's some new information out there, and I don't have it here handy with me, about how it can affect the GABA, and that's what causes anxiety, especially like the day after somebody drinks or a couple days after they drink. That particular article I read did not tell me about any long-term drinking and the rates of alcohol. It was specifically about the following day. So we'll have to keep our eye on that and see what they're coming up with anxiety related to alcohol use or stopping alcohol use. We see alcohol use a lot in this population, more so than some of the other substances, so you need to watch for detox. That's your big thing. When that patient comes into the hospital, maybe they're coming in for a medical issue and they don't tell anybody that they drink a bottle of wine every night, or a gallon of vodka a week, whatever it may be, and then they go into detox symptoms. And sometimes that's very difficult to determine if they're having medical problems on top of that. So it's important to ask those questions either to the patient or to the family. And even if they're coming into our psychiatric units, you want to ask those questions to make sure. I've had people tell me that even that are housebound, that people deliver drugs to their house. Of course, they can get alcohol delivered to their house, and so it's not as rare as you think. On page 276, you'll take a look at table 4-5, and it is about what we watch for in detox and when we watch for that. After that last drink, about 6 to 8 hours, you may see somebody with some tremors. 8 to 12 hours, you may, and that's considered mild, and it may need treatment, it may not need treatment. Just monitoring probably at that point. 8 to 12 hours, people can have moderate symptoms, which are considered some psychotic symptoms like delusional thinking and even hallucinations. A lot of times they'll have tactile hallucinations. They'll tell me feels like things are crawling on them. And then within 12 to 24 hours, you'll see some life-threatening. Let me back up. I'm sorry. 12 to 24 hours, you'll see some severe symptoms, including seizure activities. And within 72 hours, you may have some life-threatening symptoms such as DTs. I have had some patients be past that 72-hour mark, and I think they're good. And We had one not too long ago, maybe within the last couple of months, that had a seizure about 5 days out, which was unusual. He did not have a seizure disorder that we were aware of before, and so we could only contribute. The only contributing factor we could come up with was alcohol withdrawal. So, if a patient goes into DTS, that's a medical emergency. You need to address that. They can become very confused. They're disoriented. Like I said a few minutes ago, they can sometimes have tactile hallucinations. They tell me, I feel like bugs are crawling on me. Their heart rate can be elevated. They can be very diaphoretic. Their temperature can be elevated blood pressure. They usually feel anxious. I mean, they feel bad. I mean, you can tell. You can look at them and tell they feel bad and they're anxious, and they want the symptoms to go away real quick. And sometimes they can get agitated at times. Sometimes they can't sleep. And then sometimes they can be very lethargic. Sometimes there's some agitation. So you just got to treat whatever symptoms you're seeing at that point. If you think that somebody is having those symptoms on an outpatient basis, they need to go to the emergency room. I mean, that needs to be addressed. It can't just be ignored at that point if they're in DTS. Per Kaplan and Sadek, it says that DTS are most likely to begin with a patient who is in their 30s and 40s, and occurs after 5 to 15 years of heavy drinking. So if somebody comes in and they're 40 years old and they've been drinking daily for 10 years, their risk of DTS is pretty high. And of course, if they have other issues like hepatitis or history of pancreatitis, then they may be more prone to DTS. We have to watch for the neurological issues related to alcohol use, long-term use usually. We can have patients who have some symptoms that are reversible and then some that are chronic. Think about if it's chronic, it's usually related to some memory deficits, long-term memory deficits. And so we have to be aware of that. And that is treated with thiamine. And so that's why you'll see when somebody comes in that's Wernicke encephalopathy, we'll use thiamine 100 milligrams POQ day if they've been drinking heavily to prevent that from happening. Let's see. Remember that alcohol can mimic the same symptoms as major depressive disorder. So if somebody comes in and they're saying that they are not motivated to do anything, they're tired all the time, they're depressed, they may have a major depressive disorder, but they may not. If you remove the alcohol and they're still having those symptoms after several months, then you may be able to diagnose a major depressive disorder if they still need assistance with those symptoms. But if somebody comes in and they're depressed and they're also drinking alcohol, I'll usually treat those symptoms regardless if it's a major depressive disorder. Sometimes I'll put substance-induced mood disorder or something of that nature to justify starting them on an antidepressant. Take a look at table, 4.7 on page 279. There are several medical and neurological complications that can be a result of alcohol use. Sometimes when the older person comes in, they already have some of those conditions, and of course, the alcohol is going to make that worse or can make it worse. The big labs we look at are AST, ALT, and MCV. If the ALT and AST are greater than 45, then you need to be concerned. And if MCV is greater than 91, you need to be concerned. That's usually indicating that there's been some heavy drinking. And usually those labs are done on a routine basis, so it's not something you have to special order or anything of that nature. And of course, if you think somebody's drinking at that time, you can order alcohol level if need be. There is example of treatment of withdrawal symptoms in, I didn't write the page number, that's what I was looking for. In table 4.12, it's using Librium. I use Librium some. I use Ativan a lot, and the Ativan depends on how much they're telling me they're drinking. Of course, when somebody comes in, if they're in the hospital, they come in and they tell me they're drinking daily and they're drinking a fifth of vodka a day. I'm probably going to go ahead and put them on something routine like 1 milligram Q4, and then do vital signs, and then adjust if we need to. If they're over sedated, I'm going to bring it back down. If they are continue to have signs of withdrawal, then I'll increase it back up. We have used 2 milligrams PO Q4, and you just taper that as tolerated. As the patient continues to improve, you taper that down and hopefully discontinue prior to discharge. If somebody comes in and you're not real clear, you can order PRN, and they can give it, the nursing staff that's there, they can give it as needed. But I would make sure that you are monitoring for those vital signs at least every 4 hours. And those patients feel bad, so they're going to tell you most likely how they're feeling. A lot of times I use Vistaril for anxiety. I order Ativan or Librium for detox, and then sometimes the nurses will give that for anxiety. And it's hard for me to figure out if the patient's really having detox symptoms or they're just anxious. So I order Vistaril for anxiety. If they're not having any symptoms of detox except anxiety, then I'll give just the Vistaril. And usually I give like 25 to 50 Q8, and it seems to work well. The other thing, if a patient is in DTs, you may need to use IV benzos, and we don't usually give those on our psychiatric units, but they usually put those patients in ICU a lot of times and give it there so they can monitor them closely. I don't know what the policy is y'all have had experience with, but we usually don't do IV benzos on our unit. After a patient is, not withdrawing, they're stable, and you want to treat them on an outpatient basis, you need to make sure they're in some therapy and have some support. That may be individual therapists, that may be AA, maybe a combination of both, which I like. You may decide to, with the patient, to put that patient on some medication to decrease cravings, and naltrexone and Camprel are options. I've used both of those with success. Antabuse is an older medication. It's another option. I don't use it too much, and I don't think a lot of people use it very often, but I had a guy not too long ago, maybe less than a year ago, ask me for it. It doesn't really help with cravings, but if the person drinks when they're taking Antabuse, they get really sick. They have a lot of nausea, vomiting, and they can have a burning sensation per the book, but I haven't had too many people tell me about the burning sensation. It's mainly the nausea, vomiting. Table 415 is on page 284, gives you a very detailed list of these medications. And so look at that. And that's basically all I wanted to talk about with alcohol. The next thing I want to talk about was cannabis. People have lots of conversations about cannabis, whether it's safe or not safe, whether it should be legal or illegal. We could have those conversations till next week sometime, and somebody would always agree and disagree with each other. So it is not as safe as everyone wants to tell me. Some people have withdrawal symptoms like anxiety and insomnia, weight loss. There is a list of things on page 289, but I typically see anxiety, insomnia, and weight loss is what they come in and tell me. I don't hear a lot of people complaining of cannabis withdrawal, and I would not taper it down or anything like that. I would just tell them to stop it. I do see a lot of cannabis-induced psychotic disorders now. That I might be jaded a little bit because I work inpatient and people get hospitalized for things like that. So I don't know how much it is in the community, what the prevalence is, but I do see it in the hospital a lot. The problem with that is are they using plain cannabis, or is it mixed with something else, or is it mixed with synthetic marijuana, or they're buying it from the convenience store? It's really difficult to tell. So is it truly cannabis that's causing that psychotic disorder? I don't know if we'll ever know that. Some people tell me they get very anxious after using cannabis, and so obviously that's not a good choice for them. Prostatic and Kaplan, long-term use can produce some subtle forms of cognitive impairment related to memory, attention, and organizational skills. The more the person uses, the worse those symptoms are. The problem with cannabis is the FDA has not approved cannabis to treat any medical conditions. And so most of our studies and our information is gathered from the FDA doing studies or companies, drug companies, I'm sorry, let me rephrase it, drug companies doing studies for the FDA to approve it. And so we don't have a lot of that on a federal level. And so it's hard to do some of those studies and to get accurate information. People in the community tell me that they take it for anxiety, for sleep. They don't tell me they take it for nausea or vomiting or weight gain or glaucoma, but there is some information out there that does help with pain, nausea, vomiting, and weight gain. So, but nobody comes in and tells me that. Every once in a while, they'll tell me their pain management doc suggested it for pain relief versus opiates. So you've got to just factor in that people are using that. They're using a variety of things. Sometimes they'll come in and tell me they have a medical card, but they don't get the cannabis from the dispensary because it's too expensive. I basically encourage them to not buy anything from the convenience store, not buy anything from the person down the street. That if they're going to use cannabis, to please get it from the dispensary, because hopefully it's regulated and they will know what they're getting. I don't have any proof of what I'm about to say, but this is my gut feeling that I think the generation over 65 is the first generation that is very accepting of cannabis. Some of them used it when they were younger, and they're very comfortable using that now. So we may see an increased use of that with patients 65 and above. A lot of them come in and tell me that they're retired. They don't have to do drug screens. They just need to relax, and they're fine with using cannabis instead of some other medication. And I don't think that's a negative thing or a positive thing. I just think it is what it is. So please assess for cannabis use in your patients over 65. Opiate use, I think that I don't have, like I said a few minutes ago, concrete proof for this, but I think that the main abuse in this population for opiate abuse is prescription medications. I don't see, just in practice, I don't see them buying it on the street, but I think they go to the prescriber and the prescriber gives it to them and they maybe abuse it or borrow family members, that kind of thing. But you need to watch for intoxication with delirium and withdrawal. They may be at high risk for overdose because sometimes maybe they forget they take their medicine. I've had a few cases like that over the years where, someone may be under the influence of opiates and forget that they take their medicine and take them again. We just need to watch to make sure that if that's part of their medication list, then we need to pay attention to what else we're giving them or what else they're taking. Of course, I think everybody knows about the risk of opiates and benzodiazepines, and it decreases the respirations, and you will see a lot of people over the age of 65 being on both. I'm guilty of it too. I have a few patients on low dose of opiate and low dose of benzodiazepines. We just have to be very careful with that. Suboxone is a treatment option that we use in younger adults, but I don't have anybody over 65 on Suboxone or Subucade or any of those medications. I don't know if it's just because I don't treat tons of people in that population with substance abuse or if it's not common. I will get with one of the docs I work with that treats a lot of addiction and ask him what his opinion is about that. If a patient is in withdrawals, you need to treat that. You need to be aware of those. Common withdrawals from opiates, you'll see tremors sometimes. You'll see the patient being diaphoretic. They'll have a runny nose, anxiety, insomnia, pain, sometimes some GI distress. So just pay attention. If they're having those symptoms, you don't have a real reason why, you can just double check to make sure that they're not having withdrawals from opiates. Just a few things I didn't really put on the module about the benzodiazepines abuse, but take a look at that in the book. Big thing is watch for polypharmacy with the benzodiazepines and the opioids. Watch for unsteady gait, frequent falls, decreased respirations. Withdrawal is very similar to alcohol withdrawal. It has to be monitored very closely. we can't ignore that. Um, I'm sorry, I got distracted. We definitely have to be aware of that, and if they don't have their medicine, then if they're on a high enough dose of benzodiazepines, they will go into withdrawals. So take a look at table 427 and it's some guidelines for treatment of benzo withdrawal. Basically, I use benzodiazepines to withdraw people from benzodiazepines. I usually use Ativan. A lot of people use Cerax as well, but I usually use Ativan. All right, I think that's all for this little module. As always, make sure you give me, send me an email or call me if you have questions. Take a look at the readings in the book, and I think everybody will do well. On the test, I will post a study guide toward the end of the semester because this information going forward will be on test 3, which will be, I don't know the date in front of me, y'all, but the end of August. So I'll be developing a study guide between now and then and get that posted as well. All right, y'all have a good day.